Pharmacology SAQ 14. Describe the effects of inhalational agents on the central nervous system, 10 marks. Introduction. General anesthesia is an altered physiological state characterized by reversible loss of consciousness, analgesia of whole body, amnesia, and some muscle relaxation. GA can be achieved by use of volatile agents in a dose-dependent manner, leading to anterograde amnesia, sedation, and general anesthesia. Probable mechanisms of actions of volatile anesthetics: sevoflurane, desflurane, enflurane, isoflurane, and halotane are potent agonists at GABA-A receptors and glycine receptors. Potentiation of the function of these postsynaptic ligand-gated ion channels results in increasing chloride conductance, and thus neuronal discharge is inhibited. They also inhibit ion channel activity by being presynaptic antagonists at serotoninergic receptors, glutaminergic receptors, and nicotinic acetylcholine receptors. At the spinal cord level, these anesthetics diminish nociceptive afferents ascending to thalamocortical tracts. At the supraspinal level, hypnosis occurs due to influences of these volatile anesthetic agents at the thalamus and reticular formation in the midbrain. Nitrous oxide is an antagonist at NMDA receptors. This results in inhibition of postsynaptic excitatory transmission, hypnosis and analgesia. Nitrous oxide has no effects on CNS GABA-A receptors. N2O stimulates some dopaminergic neurons that mediate release of endogenous opioid peptides to mediate analgesic effects. N2O stimulates descending inhibitory noradrenergic pathways, which modulate pain processing via noradrenaline release. N2O induces endogenous enkephalin release to inhibit neurotransmission via substance P-dependent synapses. Xenon is an antagonist at NMDA receptors, 5-HT3 receptors, which results in antiemetic effects, and nicotinic acetylcholine receptors. Xenon is an agonist at 2-pore domain potassium channel, which regulates cell excitability. Additional information. Mechanism of action of volatile anesthetics are not fully understood. Theories include classical lipid theory, modern lipid theory, membrane protein theory, and other theories, which are included here for completion. Onset and offset of CNS action. From slowest to fastest onset and offset of CNS actions, the order is halotane with a BGPC of 2.3, followed by enflurane 1.9, isoflurane 1.4, sevoflurane 0.68, desflurane 0.42, nitrous oxide 0.47, xenon 0.12. All inhalational agents cause dose-dependent CNS depression, hypnosis, central respiratory center depression, and post-op nausea vomiting. Effects on EEG. At less than 0.4 Mach, there is increase in frequency and reduced amplitude due to Guidel's stage 2 excitement stage. When Mach is more than 0.4, there is reduced frequency and increased amplitude due to relative synchronization, resulting in summation. For isoflurane, sevoflurane, desflurane, and halotane, with increasing Mach, EEG changes from beta waves to alpha, theta, delta waves, then burst suppression and electrical silence. This reflects progress from awake to unconscious state. Causes of EEG changes includes reduction of activity of ARAS. This inhibition of thalamic pacemaker cells results in rhythmic discharge. Shift from complex and quasi-chaotic to simple and predictable activity, and summation of identical waveforms results in increased amplitude. Burst suppression occurs at 1.5 Mach. Isoelectric line occurs at more than 2 Mach. There is ablation of seizure activity and reduction in BIS and entropy scores. Enflurane and nitrous oxide may cause seizure activity on EEG, but not halotane, isoflurane, desflurane, sevoflurane, or xenon, which causes burst suppression at Mach of more than 2.0. Enflurane causes seizure activity at 2 Mach or more. Hypocapnia reduces seizure threshold. Effects on evoked potentials. There is dose-dependent decrease of amplitude and increased latency of SSEP, VEP, and BAEP. MEP are exquisitely sensitive to anesthetics, especially inhalational agents. Volatiles therefore should be avoided during recording of myogenic motor evoked potentials. Somatosensory and visual EPs are depressed by volatile anesthetics and to a greater extent than auditory EPs. which originate from the brainstem. Effects on cerebral blood flow. Volatile anesthetics cause dose-dependent increase of CBF via cerebral vasodilation, which reduces cerebral vascular resistance. Vasodilation occurs via reduction in L calcium channel activity and increased nitric oxide release. Isoflurane, sevoflurane, and xenon causes much less increase in CBF compared to halotene, enflurane, desflurane, and nitrous oxide. Halotene increases cerebral blood flow more than any other volatile agent. There is a dose-dependent effect on CBF. At MAC of less than 1, cerebral vasoconstriction predominates due to reduction in CMRO2. When MAC is more than 1, CBF increases as cerebral vasodilation predominates. Hypoventilation from respiratory depression causes increase in PaCO2, which may cause further vasodilation if the patient is spontaneously ventilating. Effects on intracranial pressure. Increased ICP is parallel with increased CBF. Isoflurane, sevoflurane, and xenon causes much less increase in ICP compared to halotene, enflurane, desflurane, and nitrous oxide. At less than 1.0 MAC, isoflurane and sevoflurane are associated with minimal changes in CBF and ICP. Effects on cerebral perfusion pressure. Xenon does not affect CPP, while other inhalational agents tend to reduce CPP due to their cardiodepressant effects. Effects on CMRO2. Nitrous oxide causes increased CMRO2. Halotene, enflurane, isoflurane, sevoflurane, desflurane, and xenon causes dose-dependent decrease in CMRO2. The magnitude in reduction of CMRO2 is as follows in descending order: isoflurane, desflurane, sevoflurane, and halotene. Luxury perfusion occurs as reduction in CMRO2 is not as big a magnitude as reduction in CBF. Sometimes CBF increases due to vasodilation, thus there is increase in ratio of DO2 to CMRO2, and this reduces the risk of cerebral ischemia. Dose-dependent reduction in electrophysiological function, which is 60% of total, occurs. There are no effects on basal function, which consists of 40% of total CMRO2. Basal function is only reduced by hypothermia. There is greater effect at low dose due to exponential decay nature of the curve. Effects on cerebral autoregulation. There is loss of cerebral autoregulation at high MAC. Sevoflurane preserves cerebral autoregulation better than other agents. At concentrations of up to 1 mEq isoflurane, cerebral autoregulation is preserved. Desflurane abolishes autoregulation at 1.5 mEq. Sevoflurane, desflurane, and isoflurane uncouple the relationship between CBF and PaCO2. Xenon does not uncouple the relationship between CBF and PaCO2. Coupling of CBF and CMRO2 is impaired but not ablated. Greater impairment of coupling occurs at higher doses. Effects on sympathetic outflow. Nitrous oxide is a centrally acting stimulant of sympathetic outflow. When the inspired concentration of desflurane is rapidly increased, a surge in sympathetic outflow may occur. Halotene, enflurane, sevoflurane, and isoflurane decreases sympathetic outflow and baroreceptor reflex. Xenon does not affect sympathetic outflow and does not cause circulatory depression. Effects on CSF. Desflurane increases CSF production. Enflurane increases the rate of CSF production and reduces the rate of CSF absorption. Increased CSF reabsorption occurs if increased CBF causes increased ICP. Generally, isoflurane and sevoflurane does not affect CSF. Analgesic effects. Nitrous oxide and xenon have analgesic effects via mechanisms described previously. Halogenated inhalational anesthetics diminish nociceptive efferents ascending to thalamocortical tracts. Neuroprotection. Halotene, enflurane, isoflurane, desflurane, sevoflurane, and xenon have neuroprotective effects, but nitrous oxide do not. Xenon confers neuroprotection by its inhibition on glutaminergic NMDA receptors. Halogenated inhalational anesthetics confers neuroprotection by a process analogous to ischemic preconditioning, termed anesthetic preconditioning. Ischemic preconditioning is an endogenous adaptive response where exposure to sublethal dose of ischemia reduces the extent of subsequent ischemic insults. Anesthetic preconditioning occurs when exposure to anesthetic agent prior to ischemia reduces extent of ischemic insults. APC is caused by inhalational agents mainly, but also propofol, adenosine, lidocaine, opioids, and beta blockers. With anesthetic preconditioning, which is greatest for isoflurane, the patient is able to tolerate reduction in cerebral blood flow without showing ischemic change to a certain extent. APC can be divided into early APC and late APC. During early APC, there is activation of potassium ATP channel at inner mitochondrial membrane, which restores mitochondrial ATP production and maintains closed state of MPTP. There is also opening of sarcolemmal potassium ATP channel, which maintains low cellular RMP to prevent calcium burst. Early APC lasts for 2 to 3 hours. During late APC, which occurs after 12 to 24 hours and lasts for 2 to 3 days, there is increased gene transcription of protective substances such as INOS, COX-2, BCL2, and MNSOD that deals with cellular stress, defense, and apoptosis. Neurotoxicity. Nitrous oxide has neurotoxic effects while other inhalational agents do not. Nitrous oxide inhibits methionine synthetase, and this prevents methionine and SAM production. SAM is incorporated into myelin, and its absence leads to subacute combined systems degeneration of the cord. Emergence. From slowest to fastest offset of CNS effects, the order is halotane with a BGPC of 2.3, followed by enflurane 1.9, isoflurane 1.4, sevoflurane 0.68, desflurane 0.42, nitrous oxide 0.47, and xenon 0.12. Emergence delirium. The use of volatile anesthetics is associated with emergence delirium.